Well, good afternoon, everyone. Great to see folks in the room. And also, I know we have a number of colleagues online. We are really delighted today to be hosting, as one of our Think Globals, a panel and discussion presentation on a new book, Dispatches from the AIDS Epidemic, a public health story, which has been written and put together by three of the people who really led at a critical time the early period of the HIV/AIDS response. That is Jim Curran, Jaffe and De Cock, and Harold Jaffe. I'm going to introduce Dr. De Cock and Dr. Curran just when we get to that. But a few logistics first. At the end of the presentations, we are going to have a Q&A panel, and Lance Okeke from the Duke CFAR, Associate Professor in Infectious Diseases, is going to be our questioner, focusing, I think, really on where we are now, what the future holds in HIV/AIDS and in the response. And I think I can't think of people I'd rather hear from about that than Kevin De Cock and Jim Curran. So there will be time for questions as well from us. And then, of course, lunch is there. Everybody knows that. And for the online folks, you're going to see a screen share soon. And then Kevin De Cock will go through his slides and also Harold Jaffe's. And then I think, Jim, your slides are also, Kevin is going to go run through those, right?
Yeah, I'm just sort of a commenter.
Okay. All right. Terrific. Well, just before we begin, let me say a word or two about Dispatches from the AIDS Pandemic. The book is organized into really that early period, that critical early period, and it begins on a very momentous day. I think for many of the students here, you were not alive. On June 4th, 1981. But I just graduated from college. And that was an unbelievable day. This was the CDC, Centers for Disease Control, now the Centers for Disease Control and Prevention, putting out the first morbidity and mortality weekly report at MMWR, announcing this cluster of unusual pneumonias, 5 young gay men at the time they called sexual death. But that really was the first indication that a new epidemic, a new outbreak was underway. And the unfolding story is very much the first section of the book. And then the unfolding global story, because of course, unbeknownst to us, we picked up these first cases in the US because of clinical opportunity and surveillance. But actually the virus had been spreading in Africa probably for already several decades. And that is the second part of the book, understanding global component of the pandemic. And then the third part of the book is really forward. And that's what we particularly want to focus on for this audience. So I just have to say one other kind of personal thing about this book, which is that there are many people that many of us know and have known. It is the story of response. Of course, someone named Mike Burson, everybody here knows, our founding director, is very much a character in the book. But so is the late Jonathan Mann, who really was one of the leaders, was the head of the WHO program before Mike Burson, and then was really one of the people who made the sort of first arguments about HIV as a human rights issue and as a social justice issue that had a profound impact on both fields, started the journal Health and Human Rights at Harvard. And he was divorced and married my advisor at Johns Hopkins, Mary Lou Clements. And it was an extraordinary thing to see Mary Lou, who was an HIV vaccine researcher, a very distinguished scientist, just blossom into an incredibly happy person. And they both, of course, died together in that terrible Swiss Air. They were both 51, which when it happened seemed kind of old to me. And that was kind of like, oh my God, been late. Really a loss for our field. But people who contributed, and it was wonderful to see and to read about Mary Lou in the book. So I want to thank you for that. So without further ado, let me just quickly introduce who you're going to be hearing from. Kevin De Cock is one of the distinguished leaders in our field. He was the director of the CDC's HIV program. He also was the head of the AIDS program at the World Health Organization. He's originally from Belgium, has now lives in Kenya, and is a prolific writer and leader. He's been a chairman of PROI in the past. And he's somebody who, for many, many years, has also been a leader in the fight against TB. I think is just one of the central figures in our field. Jim Curran, as I said, just recently retired as the Dean of Emory at the Rollins School of Public Health, where he was for many years. He was the initial person in that June 4th, 1981, who led what was initially a CDC task force, and then that became a division within CDC, and he was the first director of that division. And for the younger folks, you're not going to remember this, but for many of us, one of the other things that happened in 1981 was that Ronald Reagan was elected president, and he was very vigorously interested in shrinking the size of the federal government and doing cutbacks and reductions, including at CDC. So that was terrible timing in terms of a pandemic, and it was a period of great austerity. It was very hard to be working on HIV the federal government side. We're all indebted to him for not having that be a complete disaster. So, Jim, it's so wonderful to have you here. And then Lance Okeke, who, as I said, is going to be our initial questioner, the associate professor here at Duke in the School of Medicine and Infectious Diseases, my new division, happily. He also plays an important role in the CFAR, and he's very interested in the digital interface implementation science approaches to responding to HIV. So that's why I thought it would be very discussing this morning. So without further ado, Kevin, it's over to you.
Well, thank you. Thank you to Duke and to Chris, to Lance, to Michael, Caitlin for putting this on and having us. Could I have the first slide, please? So I joined CDC in 1986. I'm very much the junior member of this trio of authors with Jim Curran and Harold Jaffe. I do remember, maybe 2 decades ago saying to Jim, Jim, you really ought to write a book. And, I'm really very pleased that this finally came together. A couple of other people to thank are our editor, Robin Mosley, and also Doctors Bess Miller and Mary Chamberlain, former CDC staff members, who conducted a series of interviews for an oral history of AIDS that's available on the CDC and Emory University website as the Global Health Chronicles. I'm going to talk pretty quickly because I realize time is short, and I'm also speaking for Harold, who is traveling to the UK right now. Next slide. But first, a couple of comments about CDC. The United States National Public Health Agency. The reason it's in Atlanta is because it was a descendant of the malaria control efforts in the southern United States, but it soon extended to other infectious diseases, and of course today covers public health across the gamut. 2 important attributes are the weekly bulletin, the Morbidity and Mortality Weekly Report, which publishes important public health information, and secondly, the 2-year training program, the Epidemic Intelligence Service, so-called cadre of disease detectives. Next slide, please. So as Chris said, the book's divided into 3 parts. Section 1 deals with the early United States experience. Section 2, the CDC's early international experience. And the third part brings the story up to date. Now, it's written through the eyes of folks who worked at CDC, the three of us drawing on the experience of others also. And of course, we recognize the numerous people and broad diversity of people who contributed to this understanding this pandemic. Next slide. So as Chris explained, the story began with two reports in the MMWR on June the 5th and July the 4th, 1981, over 40 years ago now, describing young, previously healthy gay men from Los Angeles, San Francisco, and New York who presented with rare opportunistic infections, particularly pneumocystis, and/or a rare malignancy, Kaposi's sarcoma. The first cases of what we now call AIDS were reported by Michael Gottlieb, who was a young immunologist at UCLA, and he reported these to the EIS officer in Los Angeles, Wayne Shandera, quoting from the book, and we'll read passages intermittently. Gottlieb had seen 3 of these men with PCP at UCLA, and he was aware of another one at Cedars-Sinai Hospital in LA. And as Shandera recalled, Mike came down to my office, and lo and behold, there was a 5th case report in Santa Monica, a real coincidence. The 2 of them agreed to submit a report of these 5 patients to the MMWR. Now, remember, this was before fax even, let alone email. And Shandera noted that he and Gottlieb, quote, had to call in this report word by word across the telephone to CDC. Next slide. Now, the disease didn't fit any organizational unit at CDC, so a multi-specialty task force, about a dozen people, was formed and placed under the leadership of Jim Curran. And quoting Jim about the task force, he said, quote, "It was an eager group of people that came from throughout the agency, people working on cancer and virology and STDs and others, all assigned together in this task force we called Kaposi's sarcoma and opportunistic infections, because we wanted people to think and realize we considered this not just an epidemic of infections or cancers, but a syndrome, a conglomeration of things." Next slide. Now, initially, cases of such unusual illness in gay men were phoned into CDC by individual doctors, but that quickly became inadequate for tracking the epidemic. And CDC therefore developed a surveillance case definition for the syndrome, which required reliable diagnosis of KS, pneumocystis, or about a dozen life-threatening opportunistic infections in patients under the age of 60 and without a known cause for immunosuppression. And cases meeting this definition were reported through health departments to CDC. The epidemic curve shown here is from the pre-PowerPoint era, obviously, hand-drawn by Mary Chamberlain, EIS officer in New York at the time. The cases from New York are shown by the cross-hatched bars, while the open bars show the cases for the rest of the United States, showing the tremendous importance of New York City at that time. Jim, do you want to comment quickly about the case definition?
Yeah, thanks, Kevin. I think we were able, with the case definition for surveillance, to take advantage of the fact that all of these conditions were very serious and so unusual that the physician would say, "I'd never seen anything like it." Furthermore, they were all hospitalized. Now, the cause was not to be found for another 2 years, but we had to find out who was affected, how often, and whether it was increasing or decreasing. The fact that most cases were hospitalized initially led to a very high completeness of reporting, which allowed us to track various diseases. We knew that there was a larger number of people affected in the syndrome, and we called this, therefore, the tip of the iceberg. But the other conditions were far less specific and less useful for tracking the disease. When the virus was eventually discovered, we would see people going back and testing everybody for HIV, and in fact, virtually 100% were infected with HIV.
Thanks, Jim. So at that stage, a top priority for the task force was to establish risk factors for the disease in gay men. And in October of 81, so just a few months after those first reports, a national case control study enrolled most of the living patients with pneumocystis or KS and compared them with apparently healthy gay male control patients from the same cities, matched on age and race. The strongest risk factors related to sexual activity, but since sex was highly correlated with drug use, an environmental cause or a toxin could not be ruled out. The case for a sexually transmitted infection was greatly strengthened by the discovery of a cluster of 40 cases in 10 North American cities that were linked by sexual contact. The cluster investigation began when David Auerbach, now the EIS officer in Los Angeles, heard from contacts in the gay community that some AIDS patients may have been sex partners. And Bill Darrow, a CDC sociologist, went to Los Angeles to help interview cases. And quoting from the book, Darrow recalled, the first two of these men mentioned the same sex partner. There was this very handsome debonair flight attendant for Air Canada that I met. And oh God, he was such a nice guy, end quote from that patient. And when a third patient named the same sex partner, I dropped my pencil and Dave almost fell off his chair. We looked at each other with our mouths open and said, how could this be? Darrow continued the investigation in New York, and then he returned to Atlanta to present his findings. Now, sorry, could I have the next slide, please? Now, the patient at the center of the cluster is labeled with the letter O, which initially indicated a case outside of the listed cities and states. But that letter soon morphed into the number 0, and the flight attendant became known as patient 0, which was not something CDC did or ever intended to portray. So, Jim, again, we didn't know that this was an infection, but given the results of the case control study and the cluster investigation, when were you convinced that we were actually dealing with a sexually transmitted agent?
Well, several of us, including Harold and I, were engaged in hepatitis B vaccine trials in gay men, and we've been involved in epidemiologic studies of hepatitis B. The pattern of what was emerging from AIDS looked very much like hepatitis B and continued to look that way. So we had if you will, a bias to be confirmed that this was a sexually transmitted problem. The case control study and the cluster investigations further confirmed that. But, people just didn't want to believe it. They wanted to believe it wasn't something that was transmissible. And it really wasn't until the cases occurring in hemophiliacs and blood transfusion people that said, oh my God, this has got to be a virus.
Yeah, thank you. So over the next year, the epidemic expanded to include people who inject drugs, who shared drug injection paraphernalia, and also heterosexual partners of IDUs, bisexual men, Haitians in both Haiti and the US, and infants and children. And the findings from studies of Haitians were confusing, but they did suggest that the AIDS agent was primarily being transmitted through heterosexual contact. Next slide, please. The first indication that the agent could be transmitted through blood and blood products came from reports of AIDS in persons with hemophilia who received concentrates of clotting factors made from the plasma of thousands of donors. And from a December 1982 report of a single infant in San Francisco, this infant developed an AIDS-like illness after receiving multiple transfusions, including blood from a donor who subsequently developed AIDS. Now, until that December report of the infant, the mainstream media had actually paid very little attention to AIDS, but that suddenly changed. And Harold comments on being besieged by major US networks waiting to interview him. The reason for all of this probably was that while AIDS was seen as a problem of marginalized groups by most Americans, it was easy to ignore. But anyone might need a blood transfusion, and then all of a sudden people thought that anybody might be at risk. Next slide. So the American public was suddenly thrown into panic with rumors that the disease could be transmitted through casual contact or even insect bites. And some persons with AIDS lost their jobs, their housing. And CDC then responded with several studies, the first done in collaboration with Jerry Friedland and colleagues at Montefiore Medical Center in the Bronx, a study that showed no evidence of transmission from AIDS patients to household members through routine non-sexual contact. The second very important study was done in the small agricultural town of Belglade somewhat later to examine the association of HIV and mosquito bites. Recruiting participants was not easy. The lead investigator from CDC, Ken Castro, said, quote, "Think of this, you have a government official showing up at your door, inviting you to participate in a survey that's going to ask about your sexual practices, drug using habits, and so on. Not something most people would want to do. But fortunately, in the sampling scheme, it turned out that the mayor's household was part of the sample, and the mayor publicly agreed to be interviewed and tested." End quote. So the study, of course, found no evidence of HIV being transmitted by mosquitoes. Next slide. In March of '83, almost, not quite 2 years after that first report, 2 months before the discovery of HIV by Françoise Barré-Sinoussi and Luc Montagnier at the Institut Pasteur in Paris, the Public Health Service of the United States issued the first prevention recommendations. And Dr. Bill Foege, CDC director at the time, said of these early investigations, quote, "Less than 2 years after the first cases had been reported, the MMWR was able to provide an article on prevention of AIDS that is so good that you can still use it today." So this is work we should look back on and understand the power of epidemiology to define something even before the science can define it. End quote. In March of '85, the first commercial antibody test was used to screen donated blood. And in 1988, Surgeon General Koop sent his landmark report, Understand AIDS, to all American households, providing clear, authoritative information on how the virus was and was not transmitted. And that report, actually, Harold comments, still stands as a model for effective health communication. Jim, you knew Dr. Koop. What were your impressions of him? And do you want to comment on the report?
So Everett Koop was a famous pediatric surgeon from Penn and CHOP, who was a pioneer. He had also written a book opposing abortion, and this attracted the attention of the Reagan administration, particularly Mrs. Reagan, allegedly. And he was appointed Surgeon General to the consternation of everybody in public health. And it was condemned by the APHA, for example. But he was a brilliant man and bold with a strong ego. And of course, he swam upstream against the Reagan administration and then released this report advocating condom use and other things. Now, it turns out that Tony Fauci was his personal physician on the NIH campus and allegedly influenced this turnaround that he had. but he also was a very strong man who had strong opinions. And I think this led to that. I guess maybe back to the recommendations, I'm especially proud and pleased of these recommendations, which came out well before the virus was really discovered. And I think did a lot to prevent HIV transmission before then.
Thanks, Jim. So section 2, the early international response. So as in the United States, the epidemiologists were struggling to understand AIDS in Haitians. In Europe, cases were being seen in patients from Africa, again with none of the typical risk factors. And 3/4 of them were from what today is the Democratic Republic of Congo, the former Zaire. In the fall of 1983, CDC led a study in Kinshasa, led by Joe McCormick, and the results of that study were published in July of 1984 in The Lancet, along with the results from another study done by a Belgian group in Rwanda. And both these studies clearly showed an ongoing severe heterosexual epidemic in Central Africa. And this led CDC to establish Projet SIDA in association with the DRC government, NIH, and Belgium's Institute of Tropical Medicine in 1984. Projet SIDA existed for about 7 years, and over that time produced about 150 publications and close to 1,000 scientific presentations, and many of these were absolutely seminal to the field. An important collaborator was the Congolese physician Bila Kapita, who you see at the front of this photograph. And quoting from the book, Robin Ryder, on the right of the photo, who was the second director of Projet SIDA after Jonathan Mann, describes Kapita, quote, "This is a noble figure, on the same level, I would say, as Kofi Annan, just a presence. And when he speaks, charismatic, no one doubts him. He was really the godfather of the project," end quote. Next slide. As I've said, the first director of Projet SIDA was Jonathan Mann. We devote a chapter of the book to his life. After just 2 years in Kinshasa, Mann moved to Geneva in 1986 to head WHO's first AIDS program. Mann's leadership at WHO was transformational in its emphasis on health and human rights and how it forged the long-term AIDS response to this day. He was extraordinarily eloquent. From the book, describing Mann at international conferences, quote, Robin Ryder, who would succeed Mann in Kinshasa, recalled how Mann sparkled at these meetings. There was intense interest from the media in all he said. His talks at the international AIDS conferences would bring thousands of people, literally thousands of people, cheering and to tears. Alan Greenberg recalled later. There was, of course, you see also Mike Merson, who succeeded Mann at WHO. There was a lot of skepticism in those days, including and perhaps especially in Africa. But Mann succeeded in getting AIDS accepted as a global health priority, but also as an issue of rights. Quoting again from the book, major attention was initially focused on stigma and discrimination, but a broader insight was the realization of unequal vulnerability to HIV. He increasingly emphasized human dignity as core and solidarity a duty, end quote. Mann clashed with the later WHO Director General Nakajima, and he abruptly resigned in March of 1990. And as Chris mentioned, his life ended tragically in a plane crash in 1998. Jim, again, could you comment just briefly on that very first study in 1983, the work of Projet SIDA, and of course, John Mann himself?
Well, we were very fortunate to recruit John Mann, who had never set foot on the continent of Africa, to head the Projet CETA program in conjunction with Mamiemo Hospital, the NIH, the Institute of Tropical Medicine, Armed Forces Institute of Pathology, and others. And he provided enormous energy, leadership, and tirelessness to this project. His productivity was simply unbelievable. He and his colleagues published dozens of papers in those 2 years. And then, against my advice, I went to head a small program at WHO with 2 staff members and a budget of $500,000. Boy, was I wrong and was he right, because it grew to be the largest program, I think, at the time, in the history of WHO. Following his resignation and when he moved then to Harvard before Drexel, and marrying Mary Lou Clements, Mike Merson ably took over that agency, and then Peter Piot headed UN AIDS. The important thing, I think, is that it established at WHO and the international level true international leadership for AIDS, which was very important as it was recognized that the AIDS epidemic was so common outside of the United States and Europe.
Thanks, Jim. I'm going to shorten some of my comments about some of the other international aspects simply for time, because we do want to get to discussion. So the slide about West Africa. I attended a small meeting on AIDS research in Africa organized by NIH before the Third International AIDS Conference in Washington, D.C. in 1987. And there were different data presented from different parts of West Africa. And to quote one sentence from the book, it was very confusing, end quote. If a novel human retrovirus was circulating, then its distribution, pathogenicity, transmission would need investigation, as well as its diagnosis. And I suggested to McCormick, who was my supervisor, that we, quote, needed a Projet SIDA in West Africa, end quote. And Jim Curran approved of this, supported this concept, and we took it forward, and this led to Projet Retroci in Abidjan, Côte d'Ivoire, which I was the first director. And it focused on the epidemiology of HIV-2 and its disease associations. It also looked at various interventions and described how HIV-1 really overtook the whole scene, although HIV-2 remains a very important infection. But I think we have a better understanding now. HIV-2 clearly causes AIDS, but it's slower in disease progression, less transmissible throughout most of its natural history until late in infection. And this explains why we do not have an HIV-2 pandemic. Next slide. And then in 1990, a site was established, a third collaborative site in Thailand. And the 4th chapter deals with this important experience, including actually participation in the first HIV vaccine trial, the VaxGen trial that was conducted in the United States and in Bangkok. Next slide, please. Moving on to the third and final section of the book, it brings the history up to date with chapters on the origins of HIV, the current science of HIV, CDC in the modern era, WHO and UNAIDS in the modern era, and some aspects of CDC's work under PEPFAR. A couple of quotes. Extraordinary science has clarified the simian origins of what in 1981 presented as a mysterious new human syndrome, end quote. And there's detailed examination of the origins of the virus as well as the pandemic. The chapter on CDC discusses changes in surveillance practice over the years, and including the need to, once antiretroviral therapy was available, the need to track HIV and not just AIDS itself. Again, a quote, one would expect the generally dry topic of disease surveillance to arouse little political or community concern. With HIV and AIDS, this was not so, end quote. It was a very, very stormy time discussing surveillance. There's a chapter on WHO, the roles of WHO and UNAIDS, which are not always clearly separated. And I did want to emphasize Peter Piot's contributions to to contain the control of the global pandemic. I think he and UNAIDS made three important, very important contributions. The annual epidemiologic reports that became universally quoted, judgment of when to throw the weight of the UN behind ART scale-up, particularly for battles around drug prices and generics, and bringing HIV/AIDS to the highest levels of political attention globally. And the chapter on PEPFAR, again, mostly through the eyes of CDC, PEPFAR that has done so much good. A comment by my friend and colleague Barb Marston, who led our work in Kenya in the early 2000s on treatment scale-up. Funerals were the common activity. Most people went to a funeral every single weekend. The thriving business when I got to Kisumu, she said, was coffin making, end quote. So next slide, final slide. In a way, our success has made AIDS more normal, which has robbed the disease of some of its mystique. But clearly it is unfinished. And the epilogue emphasizes the unique history of AIDS, really an extraordinary story of an infection from chimpanzees and gorillas crossing the species barrier a century ago, an ensuing pandemic, years delayed, a fatal illness now controllable with just one pill a day. But what are the lessons from all of this? And that's discussed in this epilogue. How well have we learned them? And as we get close to a cumulative number of close to 100 million HIV infections since the epidemic began, have we done as well as we should have? And what's relevant about all of this to other epidemic and pandemic challenges? So those are my final comments. And Jim, perhaps you'd like to share any final thoughts before we hand it back to the moderators for Q&A and discussion. Thank you.
Thanks, Kevin. I'd like to say a couple words about you first. And one is that you've been a remarkable person throughout the pandemic, from starting at a fairly young age, Projet RetroC, and establishing a research project in Cote d'Ivoire was not an easy thing to do. It was very productive. Moving on then to, after a sojourn in London, to CDC, where you headed the HIV division and had to deal with this HIV reporting issue. And then finally, 2 stints as director of the WHO Global Program on AIDS, thanks so much. And it is all about people in different places. AIDS, of course, changed public health, it changed CDC, and it changed global health. The whole idea of what not only needed to be done, but what could be done was changed with AIDS. Initially, people thought we can't really provide therapy for people in the developing country. That's beyond the scope of public health. But AIDS proved that you can't separate prevention and treatment. And that now looks, of course, at many other diseases where we recognize the importance of that. It changed CDC and strengthened it, I think, by giving it ability to be a global organization. In the past, CDC's funding was almost entirely domestic. And we were able to use domestic funds to fund Projet CETA and Projet RetroC because we had leadership agreement, but also we were able to show how much we could show about science and the global difference and global impact. I'm worried now, not only because of recurring complacency, but because of the lack of congressional commitment to reauthorize PEPFAR. So I think it's very important to have all of us who work on AIDS see the importance of keeping our efforts going in developing countries. But thanks to all of you at Duke for the science you do and for the treatment you do and for your leadership.
Well, thanks to you both so much. I have to say, it's extraordinary to see the success, and yet we've heard very clearly from you that we're not there yet. And you both know we're supposed to have these targets where we're going to end the HIV pandemic as a public health threat by 2030, which is only 6 years away. We're not going to get there. Right? That's not happening. So, those of you who are interested, particularly the students, you will have a career in this field. I'm sorry. Have a long ways to go. Lance.
Yeah, Dr. Curran and Dr. De Cock, thank you so much. And I think first thing I want to thank you as a close relative of a victim of the HIV epidemic in sub-Saharan Africa. Thank you for your work. It's very personal to me, and we're thankful for the careers that you've led over the last 40 plus years. I want to stick on the topic of PEPFAR, actually. And so I think, Dr. Curran, you started to allude to your answer to this question, but how concerned are you about the current congressional climate in the US on the sustainability of PEPFAR? And in your view, yourself and Dr. De Cock, what does a post-PEPFAR world look like?
Go ahead, Jim.
Kevin.
Oh, well, firstly, I think I can only say that I find the congressional discussions across the board very dismaying because of the lack of bipartisanship, the focus on things that really don't matter but score political points. And all of this is in an environment, in a world that politically and is probably more dangerous than it has been since the 1940s. In fact, we see some analogies, I think, with some of the stuff that was happening in the 1930s. So I think the world is in a very dangerous situation. And of course, a problem like AIDS, which already was beginning to be somewhat forgotten because, to some extent, because of the success of the Global Fund and PEPFAR and the global commitment. So I think there's a real danger of taking our eye off the ball. Jim and I and Harold have discussed, we discussed it in the book, Chris, you alluded to it, the discussions about disease elimination or eliminating as a public health problem. These are these are valuable aspirations, but have to be handled very carefully. We've seen with other diseases like tuberculosis, all too often it's the program that gets eliminated and not the disease. And I think that, there's been some irrational exuberance in this whole discussion. Also, and I think for the students who are listening in terms of careers, as the generalized epidemics come under better control, particularly in East and Southern Africa, HIV will find refuge in key populations, the vulnerable, men who have sex with men, sex workers, people who inject drugs, partners of these groups, and so on. Post-PEPFAR, I do think the time is ripe, and I hope that as we get to 2030, towards the SDG target date, that there's a broad discussion about what do we mean by global health? What is it? What should it cover? And where does, who does it, et cetera, et cetera. I think we desperately need that discussion. HIV and AIDS drove the concept of global health to a large degree from earlier versions of tropical medicine and international health. I think we need that debate. Obviously health security is wrapped up in all of that. But so are other issues like migration, migrant health, climate change, political instability, conflict, and so on and so forth. So the time is ripe for an institute like yours to lead as you do in this evolving discussion.
I agree with everything Kevin said, and I'm worried about the world as well, and the United States as well politically. Mike Merson and I had wrote an article many years back critiquing the concept of the end of AIDS as something that was an important rallying cry at the time. But it led, I think, to some capability of disillusionment on the part of the politicians. I cringed when I saw Hillary Clinton say it because I was thinking this is just going to be the end of AIDS funding instead of the end of AIDS, largely because of the biologic implausibility of that with the given tools that we have. I mean, it's a lifelong infection. It's difficult to find everybody, but rather what we had was a very successful implementation in highly endemic countries linking treatment and prevention. And the message should not be AIDS is ended. The message should be we've established an important model in global health where we can help people with the leading cause of death in the continent and save so many millions of lives. And it needs to be continued and expanded to other problems. And so I've never liked the end of AIDS as it's a rallying cry, but it's as Chris points out, it's a rallying cry for something which won't happen, but also a lot of other infectious disease people thought it would never happen.
Thank you so much for those really thoughtful answers. And so, my next question focuses on the HIV epidemic here in the United States. And, Dr. De Cock spoke about refuge and key populations in terms of the next phase of the HIV epidemic. But I want to talk about geographic refuge in terms of the increasing peripheralization of incident HIV cases away from major urban centers because of the great public health initiatives that are occurring in those local jurisdictions, and into the rural South, into the mid-sized metropolitan areas like this one in the southeastern United States. What are your concerns for those trends, and what's the CDC's response in kind of back-in public health initiatives in this context? And then the third question I have, a two-part question, is what can we learn from Sub-Saharan Africa and the work you've done there to address this issue in the United States?
Thank you. Of course, the observation that you make very correctly of the settling of HIV in disadvantaged communities, communities of color, marginalized groups such as young, gay, Black men, and particularly in the southern United States. If you look back at the surveillance data to the beginning of the epidemic, the signal that this was happening was actually there quite early on. I say that just to point out, we really do need to pay attention to data on a day-to-day basis, because they do show the way sometimes. Public health, of course, it's often said, like politics, public health is local. And although I'm disappointed at the progress or relative lack of progress with the plan for ending AIDS in the United States that was announced under the Trump administration, I think one accurate or useful aspect of that, element of that discussion, was exactly that, targeting communities and geographic areas with particularly high transmission rates, because HIV is not like many infectious diseases, but particularly an STI like HIV, it is not equally distributed. So you have to go where the infection is. I often used to say, perhaps in epidemiology, maybe a question we should be asking more is, of the last 1,000 infections, where did they occur, in whom, and how were they acquired? And it's actually very difficult to answer, of course, but I think it's merits thinking about. In terms of the lessons from Africa, I think it's a bidirectional learning that is needed. I mean, Africa has learned a lot from the science done in high-income countries, and I think we have in high-income countries have a lot to learn from grassroots and community implementation and the role of communities, and so on and so forth. And I think, I think one thing about PEPFAR, or the approach to WHO treatment guidelines, which are more, initially they were really, really simple. They've become more complicated. But I think at a public health level, keeping it simple is really important. And I think we've done that more in Africa than here. I often ask, in tuberculosis, mostly we have one standard treatment everywhere in the world, mostly, few exceptions to that. But in HIV in the United States, there's so many different regimens. And I sort of think, that's not necessarily to the benefit of patients. So I think thinking thoughtfully about bidirectional exchange is what it's about.
I agree with Kevin again, but I have one other thing to add, and that is that we always like to try to move on to the next horizon and focus on that, and sometimes leave the old horizons behind. If you look back 40 years, 35 years, you'd say, well, most of the new infections in the United States are in gay men. And you move back 35 years later and you say, most of the infections in the United States are in gay men. Now, why is that? The main reason for that is that prevalence drives incidence. Our old epidemiologic thing of saying incidence equals prevalence times duration. And the duration is forever with HIV. And the prevalence in gay men is so much higher that the incidence is going to be higher. Similarly, the prevalence in Atlanta in the Southeast is higher, so the incidence is going to be higher. Now, that means not only that incident infections are different, but it means that prevalent infections account for that difference. So a lot of the endemic problems we have lead to the incidence problems or the epidemic problems. And then other thing is that we are so divided up in the United States on how we do things that we say, well, the prevention agency is CDC, therefore we'll give them a few $1 million and they'll be responsible for ending the epidemic in the South. But in fact, it turns out that unless you've got strong contribution from health insurance, and where Medicaid, of course, is not expanded in much of the South, with dealing with housing, with dealing with substance use, with dealing with discrimination and other things, you're not going to be able to make an impact unless you have a coordinated response. So we shouldn't be surprised that solely prevention efforts by themselves, independent of the underlying things and independent of the underlying prevalence, is going to be different. In Atlanta, for example, the prevalence of HIV, Patrick Sullivan's studies in Black gay men is nearly 3 times as high as it is in white gay men. So why should anybody be surprised to find the incidence the same? And that means we have to deal with the underlying health problems and social problems that people face, as well as just dealing with the innovative, horizon-based approaches to prevention.
Sorry, if I could just comment. I leant back to my bookshelf in response to your question, Lance. This book, My Own Country by Abraham Verghese, describes very eloquently AIDS in rural Tennessee. And the book was published 30 years ago in 1994. Very well worth reading, by the way. So it goes along with Jim's comment that, we shouldn't forget what happened a long time ago as well.
Thank you.
I think we have a moment for a question or two from the audience. If folks would like to step in. Please, Karen.
Thanks so much. So sort of jumping off about the comments we've just heard about treatment, and thinking about the debate we've had for a long time about AIDS exceptionalism and the structures in the health system. Should we be thinking about integrating AIDS-related healthcare back into primary care, thinking mostly about Africa, or should we try to keep the status quo where the AIDS-related care is outside of primary care? in Africa.
Could you hear that?
Yes, we did. Thank you very much. That's a very pertinent question. I don't think there's any right answer. I think, I think AIDS is different, but yet at the same time, you know, has a lot in. I always used to say, you know, AIDS is just a disease, but also an awful lot more. So it can learn from other disciplines, like tuberculosis, for example. There's a long history of how we get TB treatment out to communities, out to people who need it, not have it run totally separately as a separate program. On the other hand, there are advantages sometimes to very verticalized programs because you get things done quickly. But of course, then they're special and different, and the funding may run out and so on. So I don't think there's any right answer. I think integration is somewhat or more integration is somewhat inevitable, particularly in relation to my earlier comments about global health, and particularly as we start thinking more about non-communicable diseases and the need to focus much more in low-income settings on hypertension and diabetes. I don't think there's one answer, and there's no one size fits all, but I think in the longer term, there's going to be more integration rather than less.
I said in talking to students in the first 25 years, AIDS stood for AIDS is different, stupid. And then I said in the last 15 years, it's AIDS, AIDS is not different, stupid. And I think that's because there are a lot of things that apply to diabetes and heart disease and many other conditions and tuberculosis that are really like how we approach AIDS. The one thing I would say about the integration issue, I agree with Kevin about some of its inevitability, but in some circumstances, the motive is to just turn the AIDS money over to the healthcare system, in which case I think we can expect worse outcomes because the money will get diluted with all the other health problems. And I guess if I were a doctor treating a busy clinic with people and I had all this money, I wouldn't say I'm going to continue to treat AIDS separate from the others. So I'd have to worry a little bit about the outcomes if you're turning money over, but I think the idea of integration makes a lot of sense. The other issue, of course, is stigma and the question of making sure that people have access to care for a disease which is still stigmatizing throughout the world.
Jim, I think that's a great note to end on. I will just say when we last year we had an event with young investigators here with Glenda Gray, who's head of the Medical Research Council, and a whole bunch of Duke investigators talking about their work. And there were at least 3 people really focusing on stigma interventions. So we know that that's one of the many hurdles, and it's one of the really persistent ones. So thank you all. I want to thank our wonderful speakers, Kevin De Cock and Jim Curran, also Lance Okeke, for those really very thoughtful questions. And let me also just say, I'm so glad that you took the time and the effort, both of you and Harold, to really chronicle this history. It really is vitally important. And I hope somebody does as good a job with COVID. So far, I haven't really seen that, but hopefully it will happen as well. And once again, thank you so much.
Thank you. Greatly appreciated.
Thank you.